Welcome to Advanced Patient Care, a podcast series by Vance Thompson Vision. Today's podcast is featuring advances in refractive cataract surgery, and I'm your host, Russell Swan. This podcast is here to bring you the latest advancements, cutting-edge research, and practical tips that you can apply to your clinic practice right away. So, if you're ready to expand your knowledge, stay ahead of the curve, and elevate your practice, you're in the right spot. And fortunately, I've got three great people to help us achieve that goal today. So without further ado, again, my name's Russell Swan. I'm a cataract and refractive surgeon as well as cornea and glaucoma specialist with Vance Thompson Vision out in Bozeman, Montana. And we're going to start off with Keith. Keith, could you go ahead and introduce yourself and share one fun fact if you would like to, bud?
Yeah, you bet. Thanks, Russell. So I'm Keith Rasmussen, and I'm an optometrist here at Vance Thompson Vision here in Sioux Falls, South Dakota. I'm a South Dakota native. I grew up in a small town about an hour northwest of Sioux Falls. Went to Pacific University and did a residency in Reno, Nevada and Las Vegas, Nevada, and have been here with Vance Thompson Vision here in Sioux Falls for 20 years. This summer will be 20 years. Have a wife and 4 kids, so they keep me busy. But yeah, it's been quite a ride.
20 years, Keith. That's awesome. I love it. Wow. Brandon, you get to follow that up, bud.
Boy, hard to do, but feel like I've been living in Keith's shadow since I started here. I'm Brandon Bartman. I'm an anterior segment surgeon. I did my fellowship up in Sioux Falls with Keith and the group up there, which was almost 7 years ago now, which is wild. But I'm in Omaha now, and I specialize in cataract, refractive, cornea, and glaucoma as well. I'm the father of 3 wonderful children, including a newborn Molly, and I know it's a lot, but I'm thrilled, and I love cataract surgery. Honestly, I'm just going to put that out there right now. This is my favorite thing, and I can't wait to spend the next 3 hours talking about it with you guys. Because that's our time limit.
3 hours, something like that. And if Brandon just like snoozes off and falls asleep, it's probably because Molly woke him up last night. So, and in the excitement of new kiddos in the crew, Tanner, take it away, bud.
That's right. I'm Tanner Ferguson. I'm a cataract, refractive, cornea, and glaucoma surgeon at our Sioux Falls and also our Sioux City location. I'm originally from the Sioux City area, so it's been fun being back in that area, taking care of those people that I, played a role in helping me who I am today. I followed the similar pathway training-wise as Russell and Brandon, and was a medical student hanging around here at our Sioux Falls site when they were fellows. So looked up to them and was lucky to follow in their footsteps. I just joined the practice last July after my fellowship last year. And as Russell mentioned, Kayla is one of our optometrists here as well, and had the good fortune of being our first resident and trained alongside Brandon for a year.
Good fortune for Brandon.
Yeah, it was good fortune for me.
I was trying to spin this in a positive light, okay? Fun fact, I have more hair than Keith, but less flow than Brandon. So into cataract surgery.
Sweet. Well, our kind of flow, so to speak, for today is we're going to kind of talk through the preoperative exam. That's going to be our first part. And then session 2 of this discussion is going to be talking about all the great lenses that are now out there in the refractive cataract surgery space and how to have a conversation with your patients about that. And then I'm super excited. Part 3 is going to be sort of what would you do? What would we do if it was our own eyes? What would we do with some case examples? And then we'll walk through the post-op. So let's jump into the pre-op part. And Keith, I'm going to throw this to you first. We have thousands and thousands of patients that come into our clinics every year to see us for a cataract evaluation and have a conversation. Can you kind of walk through what that experience is like from a standpoint of when they walk in the door and what things we're testing, what things you're looking at, and what things you're talking to them about?
Yeah, sure. Thanks, Russell. So, we're blessed in all of our locations to have a lot of amazing referring optometrists that send patients in to see us. So we're blessed to work side by side with a lot of optometrists. We mainly just do surgery, secondary and tertiary care type of thing. So we don't do any primary care. So a lot of times those patients come in and see us and they're already well on their way of being educated from their primary optometrist. We have an excellent staff here as well that will send patients out videos and pamphlets and give them phone calls. And so a lot of what we do is about education. And I think we'll probably touch on this in a little bit, but you know, a lot of times patients will come in and kind of have an idea as far as what cataracts are all about and what types of implants they want to do. But when they come in, we're just kind of honing in on what's going to be the best for their eyes and how they want to see after surgery.
Perfect. Brandon, I'm going to have you get into some of the nitty gritty for us, if you don't mind. So I'd love to kind of talk through, you know, what the common diagnostic tests that a patient's going to go through as part of the preoperative exam, and maybe kind of highlighting why some of those tests are important, even though many of those we may not charge for, but we want that information. So maybe walk us through some of that.
Yeah, and that's it's a hot topic, and it's an evolving topic, right? Because I feel like even since I started the practice down here, you know, almost 6 years ago, it's changed, right? Because the technology changes and it gets better, and we use different information in different ways. And so, you know, we have kind of a large number of tests and scans that we'll put patients through in the most, you know, efficient way possible. But we've got a lot of data we need. So, of course, for any cataract surgery, you know, we're paying attention to their ocular history. We're taking a good ocular history. We're taking, like Keith said, we're taking into account their personality and what they're looking for. But from an objective standpoint, we need to know what's their habitual refraction, right? What are they used to in terms of contact lenses or glasses? We like to get an auto refraction on them. Of course, we want to have a biometry so we can get a measurement of the front surface of the eye and the length of the eye so we can come up with an accurate lens power. But we also start using things like topography, right? We use topography all the time, not just in measuring the corneal power, but in noting the regularity of the corneal surface and the tear film, and how sharp are the mires on the disc reflecting off the cornea. The other technologies we're commonly getting are OCTs. OCT is becoming more and more important in ophthalmology, not just anymore for getting a scan of the macula, which we do on every patient, but the optic nerve, right? And understanding the health of that optic nerve, as well as, more recently for me, the thickness of the epithelium, right? So we're learning more about epithelial thickness profiles. Maybe we get into that in a little more depth because I think it's worth it. But understanding the pattern of thickness on the surface of the eye and how it may have changed in relation to dryness or keratoconus or post-refractive surgery. All of these things can play into, you know, the kinds of things that we're thinking about when we're trying to select the right lens for a patient.
Awesome. Tanner, I'm going to have you expand on one of the things Brandon talked about, because when, you know, back in the day when Brandon, Keith, and I were in training, there was, you know, higher order aberrations were kind of a made up word that maybe 2 or 3 people knew about, but not very many people did. And now it's kind of in the common vernacular of what we talk about every day when we're evaluating a cornea. So can you maybe talk about, you know, 1, what are higher order aberrations? 2, how do we evaluate those? And why do they matter when it comes to our conversation around cataract surgery?
Sure. So higher order aberrations are essentially small irregularities present in your cornea. We measure them, and there's a few like common types that people will talk about. The 3 most important are spherical aberration, coma, and then trefoil. But the ones we most commonly hear about or easy to relate to visual significance are coma and spherical aberration. And in all of our sites, I think we almost all have a NIDEC or an OPD or a Pennicam, and both of which can measure the magnitude of corneal higher order aberrations. And I think getting a quantitative measurement and then I think everybody probably has a different comfort level with, in terms of like a certain level. I think on the NIDEC, most people get concerned when that level is above, for the total high order aberration, when that total is above 0.5 for the cornea. They start to get a little bit nervous about a more advanced or diffractive IOL. And, you know, I think over time we've learned how to use that information to guide the IOL decision-making discussion and process. And we've also learned that the IOL technology has improved to where, I think we used to be more conservative with those numbers, but with the advancements in the IOL technology, I think we're willing to push a little bit more. But I think, like you guys said, I've been really lucky. I've used that since day one in practice. And I think it's a helpful tool to making sure the patient's going to be happy with the IOL that we put in their eye.
Okay, so some quick survey. Brandon and Keith, is it trefoil or trefoil? Brandon, what is it?
Trefoil.
Trefoil. Keith?
I say trefoil as well.
Oh, see, that's what I meant. So I don't know, but Tanner's going trefoil.
You guys ever heard about trefoil?
It's very green. It's very
way more important than trefoil.
I don't actually, I don't know what it is, but I'm going to feel bad if Tanner is right.
I mean, I feel like he probably is right, but trefoil sure sounds cool, I think.
That's right.
And then the second thing I'd love for you guys, when you think about, particularly the scans that we're getting. So if I had to tell you preoperatively for your cataract evaluation, you have a IOL or optical biometer, you have a regular topography, you have a way to evaluate higher order aberrations, and you have an OCT. Top to bottom, most important to least important, how are you rating those four things for great cataract surgery outcomes? Keith, you got to take it first.
Oh boy. Well, I'd say the biometry is most important just because we need to figure out what power of implant's going to go in the eye.
Trick question.
But the cool thing about this is the instruments that you just listed off have a lot to do with refractive surgery. And so, this cataract surgery nowadays isn't just everybody gets a monofocal implant. And so that's the cool and exciting stuff about what we're talking about today is it's really refractive surgery and how we talk to our patients, how they want to see after surgery with glasses, without glasses, all these other pieces of equipment, topographies, OCTs, NIDEX to get high order aberrations. They're all coming back to the refractive status of the eye and how we're going to maximize that. So I think kind of basic overall arching to answer your question, I'd say biometry first is so we can get an implant in the eye. And then I'd want to see topographies, high order aberrations, which probably goes along with topographies, and then OCTs.
Anyone say differently?
No, I'm exactly the same for the exact same.
I mean, I was just going to say I was going to pull a Vance and say all of them. You can't rank me, force rank them. We'll take them all, which is kind of our approach. But there are a lot. I bring it up because there are a lot of practices out there. To your point, Keith, that don't think of cataract surgery as a refractive surgery, and they may say, "Hey, just an IOL biometer is just all we need, and we don't need to have a topography, and we can put a toric lens in without a topography." And oh wait, that patient had irregular astigmatism, and maybe that wasn't a great option. So I do think all of those really play an important role in kind of what we do today. Brandon, I'm curious, can you jump through for me when you think, Keith talked a little bit about when we have patients coming in, a lot of times they've already been seen by a primary eye care provider. What's kind of the most important information or most helpful information that you're seeing on a note coming in for you for a patient that has a cataract and is being referred to you for surgery? What are the most helpful things that a primary eye care doctor can do to help prepare that patient and also to help prepare you for the conversation?
Yeah, I think this is a really, really important question and something worth spending some time on. Every referral, I hope anyway, and in most cases, like we've got a great network of docs that send in, and most all referrals have these forms that are addressed to us with the patient's history and things like what is their best corrected vision, right? And what's their visual potential, right? We have the question on there, when were they at their visual potential? How long ago and what was it? And then their ocular history, like this patient has been a habitual multifocal contact lens wearer for a long time, or a patient loves monovision, or all of these little important details about their past experience with these patients. I can't overstate how important those things are to me, because I use that information not only to help like guide appropriate care and make sure we're not missing something like a history of LASIK or something else, right? But also, equally important, it helps establish that relationship connection between us, the patient, and the referring doctor. It's like when the patient leaves their office scared, knowing, oh my gosh, I came in for new glasses and now you're telling me I need to have surgery to see better. If they know that we're in communication, like, oh, hey, I got to review this note from Dr. So-and-so. They were mentioning to me about this, that, or the other thing. All of a sudden, the loop feels more closed and secure to a patient who's already feeling vulnerable. So equally important to the information I'm getting is what that communication means to that patient.
Perfect. I love it. I think that's a great kind of wrap up commentary on the preoperative section. And again, I think it's this beautiful meld of the information you get on the front end from someone who's had a long-term relationship with a patient, and then taking that information and blending it with the, great technology that we have to evaluate their eye to know kind of what options are best for them that really create a beautiful spot. So what I'd like to do. Yeah.
Russell, do you mind if I mention one more thing?
I would love it.
All the technical stuff that we get, visual acuity, biometries, that sort of stuff. But one of the more meaningful things for me too is what's the patient do for an occupation? What are some of their hobbies? Because we're going to learn a lot about those things in terms of how they use their eyes and how they want to see after surgery. And so that for me is huge in helping a patient choose which type of IOL would be best suit their lifestyles.
Yeah, Keith, I think that's such a great point. I think about, my parents who have not had cataract surgery. They're beating the average, but they're getting to the 70s. And my mom loves to be in her sewing room as much as possible and loves that super, super fine up close vision. And my dad could drive 12 hours in a day and just think it was the greatest day in the history of days. And their visual desires might be a little bit different, either occupationally or hobby wise. So I think that's a great, great point. So Tanner, any other closing thoughts you have on the pre-op part before we jump into the next section?
The only other historical point that I think is important to include is, does the patient have prism in their glasses? Because no matter what lens we put in their eye or what cataract surgery we do, they're going to need that prism after surgery. And I think it's always an important thing to pick up when you're evaluating a patient or sending them. So,
yeah, great point. Absolutely perfect. And last, and I would just highlight again the comorbidities that a lot of people talked about. The last podcast series talked a lot about how do we deal with glaucoma as a comorbidity, both in terms of MIGS surgeries, but also in terms of IOL implants. Obviously, macular degeneration, diabetic retinopathy, a lot of those things do play a big role. So part two, what we're going to do, we're going to jump into some of the fun technology that we have. So the lenses that are now available, and then kind of how we talk to patients about it. So honestly, this is the part I think, Keith, you are our senior wisest person, but I think about your career arc and the improvement that you've seen in IOL technology. It's pretty remarkable. Maybe I'll let you jump in this first in terms of just, talking through, hey, what implants did we used to have? Not to say that you're ancient, Keith, you're young at heart, but what lenses now do we have that really have increased the opportunities that we have for patients?
Yeah, well, I think all implants, ranging from standard monofocal implants, toric implants, to even multifocals, have improved. I remember I was doing a fourth year rotation at the Moran Eye Center in Salt Lake, Utah, where you did, Russell. And there was a grand rounds on light adjustable lens back then. And I thought, oh my goodness, this is the future. Well, a year later, I joined Vance Thompson Vision and he's doing light adjustable lenses. So it's kind of fun to see, now it's 20 years later, we're still doing those. I think one of the main things that we're seeing in, monofocal is just being able to adjust for spherical aberration has been huge in helping out with nighttime issues. And then same thing with any multifocal or diffractive or EDOF lenses, just improving image quality. It used to be back in the day, it was, we can do a multifocal for you, but your image quality and contrast sensitivity are going to be reduced. Nighttime glare is going to be kind of off the charts. And that was tough to deal with patients, and whether it was worth the investment and extra surgery. And nowadays with modern multifocals, and I know they're going to continue to improve and they're not perfect. We'll probably talk about that in a little bit, but I feel like we're almost in the golden age of multifocals. This how far we've come. And it's just so impressed, or I'm so impressed seeing patients not only being able to see distance near, but good nighttime image quality and just quality of life.
Awesome. Tanner, I'm going to let you jump in on this because, there's kind of two ways I think to think about the lenses. There's, we can jump into all the specifics of the lenses. The other view is kind of talking about, hey, what are the visual outcomes that maybe our patients are interested in? And then kind of what categories of lenses maybe fall into that. So maybe do you mind, and I generally think the, visual outcomes perspective is how our patients think and is maybe most helpful for us to think as doctors. So do you mind kind of walking through, what are the different visual outcomes that we could be thinking about for our patients with cataract surgery? And then what kind of classes of lenses fall into those sort of visual outcomes?
Sure. Are you trying to get at like how do they want to use their eyes with or without
Oh,
glasses?
this is a big test. It's kind of like trefoil and trefoil. I'm just seeing if you'll mess it up so we can harass you a little bit.
Take whatever you want him to have said and just run with it. Talk about whatever you want.
You can talk whatever you want about. That's a great part.
Ask more ambiguous questions, okay?
Yeah.
Yeah, I think when I had the lens discussion with patients, I kind of frame it like, how do you want to use your eyes after surgery? And do you want to have some freedom from glasses? If your main goal is to have maximal image quality at distance and some freedom from glasses at intermediate, then I'm more thinking about light adjustable lens or an extended depth of focus lens. If their goal is to maximize their freedom from glasses as much as possible and not have to wear glasses for 99% of the things they do, then I think more about a trifocal option. And then there's a lot of nuance within that, or for other choices for why LAL versus PanOptix versus extended depth of focus. But I really start the conversation with, how do you want to use your eyes? And then in some cases, if the patient doesn't mind wearing readers and is most focused on having maximal image quality at distance and they have some astigmatism, I still think there's a good role for a monofocal toric. I'm still amazed that I do more monofocal torics now than I did during fellowship, and those patients are always so happy with their vision.
Yeah.
I'll add to what Tanner said too, and this is just kind of an overarching high level point. What we're seeing now that we have, for a long time we had those categories, the multifocals, and then and monofocal and toric, and then came extended depth of focus, and what we're seeing is further iterations on each of those things, and they're starting to blend between, right? We've seen a dramatic advancements even in monofocal technology that edge towards more of an extended depth technology, and so now there's a new category called monofocal plus, right? So it's an incredible time to practice cataract surgery, which is, like Keith said, refractive surgery, right? And if it wasn't refractive surgery, this iteration of technology wouldn't continue, right? Because it wouldn't matter. So that's a great point, Keith. That is refractive surgery. The other thing I'll say that I'm going to contrast with Tanner just a little bit, and I think we're getting to the same point, but I do it a little differently. And this was a recent change for me. But instead of asking patients how they want to use their eyes after surgery, what I ask them is, how well do you want to be able to see without glasses? That's it. And I let them run with it. Totally open-ended. They can decide, whether they think I'm talking about distance or up close. They can clarify for me. And it's all about trying to get them to answer the question, how well do you want to see without glasses? They say, I want to see well without glasses, because who doesn't, right? It puts them squarely in the mindset that, okay, I'm going to have surgery. This is going to change my prescription. How well do I want to see without glasses? And what technology, and then they tell me, and I tell them which technology will help achieve that goal, right? And so I feel like it's simplified the process for me a little bit. So I hate to disagree with Tanner, because he is my junior, but I just take a slightly different approach.
Yep.
Yeah.
And mind if I add a couple of things? There's a couple other questions that I like to ask patients, especially myopic patients when they come in, especially females. Is, do you take your glasses off when you look in the mirror to do makeup? Or guys, do you, shave without glasses? Because that's an important question to ask the patients too, because if they're myopic and they read without glasses, or again, simple things like shaving or putting makeup on. It sounds kind of small, but when they do it every day, if they were myopic pre-op and we don't ask them that question, we put a monofocal and make them distance, they're not going to be happy when they're having to use a magnifying mirror to put their makeup on. And so that's something that I like to ask too, is if you're okay with glasses, you know, and you'll wear them most of the time, but the small percentage of the time you don't have glasses on, would you rather see a little more at a distance or up close? And on top of that, I like to ask patients with progressive addition trifocal glasses, do you do okay with that? Some patients, it's not a lot, but there are some patients that are okay with glasses. They just don't want to wear trifocal glasses because they have a tough time stepping down a curb or off steps. And that's where I've even had a couple of patients recently that want to do a multifocal implant, but still want to wear glasses because they're just single vision glasses. Their grandkids won't know them without glasses. So they kind of like the fashion style of glasses, but they just don't like the maybe depth perception, you know, issues that they're dealing with multifocal glasses.
Nice. That's a great point, Keith. And I'd be curious, anyone can take a stab at this, but I'm curious, you know, sometimes I get asked from some of the primary eye care doctors here in Montana, you know, how much of that conversation should I be having on the front end? And I guess I'd be curious kind of your guys' thoughts on, you know, where does that conversation belong, whether it be in a primary eye care office or with us? And if you think it's helpful to be in the primary eye care office, you know, what maybe tips you have for starting that conversation if it's somebody new?
I think, go ahead, Brandon.
No, this is a Midwest standoff.
No, Tanner. No, Brandon. No, Tanner.
I think it's really helpful when
Brandon won.
The patient's already had a conversation with their primary optometrist, because in general, the primary optometrist knows that patient way better than we are going to know that patient when they come into our office, because they've, in most cases, have been seeing that patient for many years. So they have a good understanding of that patient's visual needs and their likely goals for after surgery. And so they're probably better equipped to have that initial conversation than we are in terms of making a recommendation based on their visual goals. And, you know, when we start talking about these different IOLs, this is a big decision. And so if we just throw all this information at them in one single visit and expect them to make a decision in 15 minutes, you know, it's easy for them to feel overwhelmed or have some decision paralysis. So I think if the primary OD or the primary optometrist can have this conversation and set the stage early on, I think it only helps the patient be a more informed person and make a better decision.
I'm with Tanner 100% here. Finally, on the same page.
It only took us a half hour to get a line, Barbie.
Yeah, it feels good. It feels good, folks.
Thank God we got 2.5 hours left.
Yeah. One thing that I've always said, and it kind of guides me in how I try to practice, is an educated patient is a happy patient. And to take that a step further, right? An educated patient with time to consider is a really happy patient, right? Because that allows them that process that everybody has to go through to not feel like something is an impulse, right? They go through this, okay, kind of in their mind testing out different scenarios of what was presented to them. And the earlier they have that opportunity in the process after having found out they need cataract surgery, I believe the happier we can make that patient, regardless of which lens they end up choosing.
That's a great point. Keith, other thoughts on that?
I agree 100% with both those guys. You know, the primary care optometrist is seeing that patient more often than we see him. They know him better than we know him. It's one of the reasons I love our See and Do program so well, is because a lot of times the optometrist will have that conversation with the patient, and they don't necessarily have to get into all the nuts and bolts of every little optics of every lens, but just give the patient somewhat of an idea about different options. And then in our See and Do program, our patients are getting called, they're getting videos, they're getting pamphlets. One of our doctors is calling them before they come in. So they're hearing about this stuff 3 and maybe 4 times before they even come in for an evaluation. And so I feel like that has just alleviated a lot of anxiety from the patient's perspective. They can involve family members in their decision-making process too. And that's just been a game changer. And again, we're blessed to be able to work with a lot of very knowledgeable optometrists that are educating on the front end of this whole process.
Yeah, that's beautiful, Keith. And I think, Brandon, the see and do process was something that started at Vance Thompson Vision a little bit before you joined, but can you walk through that from a patient experience perspective for the patient, what that involves and why we've found that to be in our region a really nice win for a lot of our patients?
Yeah, this is a great question, and I wonder if we'll have listeners from outside of our region that might seem a little foreign to, but the Midwest is big. There are vast expanses of ranch and farmland and rolling hills, and it's beautiful. Come visit. But the reality is, a lot of our patients are coming from a long ways away, and it's a meaningful practice to try to limit how much they want to travel. And by the way, they're patients with cataracts and they need a driver. And a lot of the coordination has to take place in order for them to have surgery. And so what a see and do is for that patient is an alert from their doctor that they're interested in this program. And our team jumps into action. And basically we've got patient advocates that specialize in connecting with these patients ahead of time, having conversations with them, sending them a folder of information from maps on how to get to the clinic and surgery centers to their IOL options to start those conversations, which can then be continued by one of the doctors in the office, oftentimes who may call that patient before they arrive, so that this all feels like a connected experience to that patient. And then they're anticipating with excitement instead of anxiety that day of surgery. And that day comes and they come and see us for not only their surgery, but we do the evaluation that day too, right? And we go through all of the stuff that we normally would. It's not abbreviated in any way, except in the perhaps the counseling and the decision making, because a lot of that stuff can take place ahead of time too. And so it's a beautifully efficient process to have an evaluation and surgery on their first eye that same day. And one of the things that we've tacked on to that program is what we call next day surgery, or close sequential bilateral cataract surgery. Instead of doing one eye one day and one eye the next week or 2 weeks apart, we knock them out in back-to-back days. And so from a patient experience standpoint, our folks from Western Nebraska love this because they come stay overnight one night in one of our preferred hotels and back the next day for surgery and home to their local optometrist or eye care provider. And it works really, really beautifully.
Could they go watch the Huskers the day after their surgery too?
Yeah, depends on how disappointed they want to be with not their vision. I love the Huskers. Not their vision.
We're talking about volleyball.
Yeah,
yeah. We're winning the national championship next year.
That's right. Next year.
Sounds good. Awesome. Well, what I'd love to do, we talked a lot through some of the lenses and options in the conversation. We're going to jump into the next section, which is sort of a what would you do section, which I'm super excited about. And we'll maybe get a little more into the specific nitty gritty of some of these lenses just based on clinical scenarios. But I'm going to start with a couple questions first that are maybe applicable or theoretical. So first, if you guys were having cataract surgery and you had the choice of doing your two eyes a month apart, a week apart, a day apart, or the same day, what would you choose?
Closest to
Tanner,
surgery goes first.
Oh, Tanner.
I didn't hear what you said, Brandon. You spoke way too fast. I would have mine done in the same day, especially if Brandon was a surgeon.
Oh, wow. Me too. Maybe we can do each other's on the same day.
Great.
I would do the same thing. I would.
I'll do the surgery. I'll do the surgery first.
Keith, what about you?
I would probably do them a day apart.
Okay.
I've been lucky enough so far in my life to never have any eye surgery, and so I would probably have just a little anxiety, even though I see it every day. I see how well people do. I always think about back to the time that my wife had LASIK, and I was so nervous, even though I've seen hundreds or thousands of Vance's LASIK patients do beautifully. Just from an anxiety standpoint, I'm a little nervous Nelly, I guess. I would probably do one eye in one day. Kind of like what we're doing now. We check that eye the next morning, make sure we're all feeling good about it, and then do the other eye the next day.
Perfect. Yeah, and I think just as a point of reference and good to know, I mean, for the last 5+ years, we, in Montana, and I think a lot of our locations, probably 95% of our cataract patients, choose to have cataract surgery a day apart or a couple of days apart. And again, it's reasonable to do a week or 2 weeks apart, but the beauty of sequential 1 day apart is it's one healing phase. They get back to normal and back to life as normal more quickly. For family members who are driving them, it's just much, much easier. And I think the one logistical hurdle and financial hurdle that prevents us from doing same day right now is just the insurance aspect. So there's managed care organizations like Kaiser and the VA and other places outside of the US have published, enormous databases of information and case series of patients where the safety is really spectacular. And so hopefully, one day, by the time Tanner and Brandon need surgery on the same day on each other, we'll be able to do that from an insurance perspective, which is nice. So we're gonna kind of just do a case where I thought it'd be fun actually to start with, and then we'll jump into some kind of more squirrely cases. But first would be just for your own eyes. So your own eyes, if you were having cataract surgery today with the technology that we have, what lenses you would be choosing for your eye? And you can maybe kind of walk through in terms of, are you emmetropic, nearsighted, farsightedness? What's your ocular history that might impact that decision? So Keith, I'm going to let you tag this first since your eyes are perfect and you've never had anything wrong with them.
But you're also asking me because I'm almost 47. I'm getting a presbyopia right now. So, I actually am starting to have to stretch things out a little bit to see a little bit more. And so I am valuing my near vision more now than I have in the past couple of years. And with the advancements of multifocal implants, I think for me, it'd be a no-brainer. I'd do a multifocal implant. I want to be able to see my kids out there on the ice and be able to see the program and see my watch and those sorts of things. And I don't do a ton of nighttime driving, even though halos have been minimized. Nothing great happens after 8 o'clock anyway, so I'm in bed early. And so for me, I think it's an easy decision.
Good luck, multifocal.
What are the multifocals?
Good luck as the kids get into junior high and high school and start
I know,
checking home
I know.
late.
8 p.m. curfew in the Rasmussen house.
I know.
Once
they
my
can
dad goes to
drive.
bed at 8.
Oh boy.
Brandon, what about you, bud?
The perspective is a little more challenging because I'm not presbyopic and I'm probably not even close. But here's my thought process right now. In all honesty, I have had LASIK and I had quite a bit of astigmatism in my LASIK prescription. And I've been following, obviously my topographies and my epithelial thickness maps, and I've got, not a super normal epithelial thickness profile. And one of the thoughts, of course, anytime we're going to choose, a technology with a patient, we say, what's my likelihood of success here? And I think even post LASIK, the formulas are so good that the likelihood is still really, really high, that we'll nail it. And then what am I going to do if I need to adjust? Like, is there an adjustment plan for this particular patient if there's a little residual refractive error, right? Because you need to have those things thought out as a refractive cataract surgeon these days. So for me, I really, really like LAL technology. That's the light adjustable lens. I think I've seen particularly post-refractive corneas do so beautifully with this technology. And we have so many happy patients, especially with just a little bit of blended vision, that I think that might be the direction that I would go. Although a true multifocal would be really, really tempting to me, I just wonder about how particular I am and how my LASIK would play with those diffractive optics. We have a ton of patients that we use PanOptix post LASIK in, and they're very happy, right? But they're also presbyopic and super motivated, and I may get there, right? I may get there too. But right now, I'd probably say LAL.
Tanner.
Yeah, I was actually having this debate when, you sent over the questions ahead of time. I was having this debate in my head whether I would go LAL versus PanOptix or like a trifocal. I don't know if I'm a very particular person.
We'll ask Kayla.
Yeah, we know somebody who would know.
I have that fear too. I could see myself being particular at distance, and wanting to maximize my image quality at distance. But my image quality has always been great after my LASIK. I never had any issues with halos or seeing at night, things like that. So, and Keith took a look at my flap immediately after my surgery. So I know it's pristine, advanced in my LASIK. So I feel comfortable that even if we are off a little bit off target with a multifocal IOL, that it's a flap that's safe to be lifted. So I probably would land on a trifocal and
Nice.
take on multifocality.
Perfect. For my own eyes right now, with the technology that's out there, I'd be in Brandon's boat. And a little history there. I was a previous, -625 spherical myope. So I have, a relatively flat cornea. Had thin corneas to start with, so I had PRK. And so I don't have a lot of room for flexibility. And my higher order aberration profile is on the higher side. So for me, just from a vision quality and ability to kind of enhance and refine that refractive target, for me, that's where LAL would be a nice win for me if I were having to have cataract surgery right now. So I'm going to throw out another case because this maybe applies to some of the new technologies that we have, and particularly how we think about a standard monofocal or a toric, an extended depth of focal, a light adjustable lens, or a pinhole optic. So I just had a patient last week, previous 8-cut RK, mild irregularity to their cornea, but less than 2 diopters, had about a diopter 1.25 on one eye, 1.5 diopters of astigmatism on another eye. Like many patients who had previous RK, interested in some refractive freedom, particularly for distance. They'd love full range of vision, but realize that maybe isn't possible, and is curious what would be kind of the best lens options to give them better nighttime vision quality and maybe a little bit of range of vision. So Keith, I'm going to let you take a swing at this one first. What range or what kind of lens choices are you thinking about in this patient? And do you have a go-to for this one?
Yep. One of the first questions I'd ask that patient too is, how was your vision right after you had your RK? If it said it was amazing, that opens up a few more choices, whether it's light adjustable lens, pinhole, IOL, or even an EDOF. In our practice, I would say most of those patients were using light adjustable lenses. I feel like this is a sweet spot for light adjustable lens. We put the implant in the eye. We wait probably about 2 months, especially post corneal surgery. Sometimes those refractive changes can linger for a little bit longer. But the cool thing with people that have had previous RK is they have almost a little bit of multifocality built into their cornea. And so when you do a light adjustable lens and you target one eye plano and the other eye -0.5, -0.75, with that multifocal cornea, those people are reading really well. And so those are actually some of my favorite patients to work with LAL. Now it's a journey, and patients have to understand that it's several months, but those have been some of my favorite patients to work with. And most of the time we're doing LAL.
Beautiful. Brandon, what if we took that same patient and instead of 1.2 diopters or 1.5, they had more irregular astigmatism and maybe 2.5 to 3 diopters of irregular astigmatism, and they particularly even pre their cataract have kind of been frustrated by their nighttime vision quality, and they have a little more irregular corneal topography. Would that impact your decision in terms of what lenses you're thinking in that patient?
It certainly does. One of the important kind of forks in the road for us when we're thinking about irregular corneas is this eye, for best vision, is this eye going to be contact lens dependent, right? Is their best vision really going to be just a lens, or are they going to need like a scleral lens, right, to see their best? I mean, keratoconic or RK or you name it, post-keratoplasty, we've got a ton of irregular corneas out there. And so I always try to decide, like, are they going to be looking through a fluid dome and normalizing that cornea, and we're going to want some other type of optic in there? So that's a decision point for me. But when you're talking about more of the higher order aberrations, and of course the light adjustable lens corrects aberrations, but only the lower ones, right? And so So, so when we're talking about really aberrated corneas, we're starting to say, okay, do I want to consider doing an aphthera, right? Aphthera being the pinhole IOL, which can help kind of eliminate some of those peripheral light rays that end up scattered and causing contrast problems and reduction in visual quality. Can we improve that with one of these pinhole IOLs? And if not, we have, even in the cornea you're describing, Russell, we have seen success with the LAL, right? When you can't really identify how much of those lower order aberrations they are on the cornea, where that prescription is going to wind up. If they say, hey, I want anything possible to maximize my vision without the dependence on contacts or glasses, then I think, LAL can still be on the table, right? Aphthera is on the table. And then when you get to the really irregular corneas and they say, I really need to see better, or they're already contact scleral lens dependent, then we might be having the conversation about a monofocal being the best choice for them, because we don't necessarily want to go down the road of having a oddly shaped advanced optic or a toric and having to do some fancy stuff with contact lenses afterwards.
Awesome. Tanner, any other thoughts on either of those two scenarios?
I think in the more irregular cornea and, looking closely at topography and depending on the extent of irregularity, I think it's a good opportunity to use a gas perm over refraction. So they don't have much cataract and they're like, 20/40, but then they improve to 20/25 with a gas perm over refraction. That might mean they could benefit from an IC8 or an aphthera, a pinhole optic. It might also mean that they're going to be contact lens dependent. And then the only other thing I would add to this discussion, because I had a patient like this, is I, like Keith, prefer the LAL in these post-RK patients. I've been amazed at the outcomes. But you have to remember the dilation, because you need adequate dilation for the light delivery after the surgery. So I had a patient recently who had 4-cut RK and had a relatively normal topography for a post-RK patient and loved his vision after RK. And so we actually did an EDOF in him because he only dilated to 5.5, and he's been doing great. So
nice.
It's great point, and really, really solid reminder again, because those adjustments happen post-operatively. We want to see them dilating greater than 6.5, ideally maybe even 7 pre-operatively, to know we'll be able to get complete focus on the IOL optic at the time of the adjustment. So that's super great. Okay, so one of my other favorite class of patients is, we'll just call them the particular type. So, we sometimes use a Dell questionnaire, and it's like, hey, I'm like super easygoing, or like I'm super type AAA and very, very particular. And they kind of write to the right of that spectrum, like I'm even more particular than a particular person. And they might be a pilot or they might be an engineer. But let's say, Brandon, I'll throw this one at you. You have a near emmetropic patient like Keith, but they're a little more particular than Keith. They're a pilot. And they are, they would like the most visual freedom that they can have, and they would like the most visual range that they can have. And oh, by the way, I also want the absolute best optics that I can have. What things are you thinking about there for lens choices? What advice are you giving to that patient? What considerations are you making also, even just in terms of like, are they a private pilot or are they a commercial pilot? Maybe walk through something like that.
Yeah, this is really good.
I saw a pilot today.
I did too. So, okay.
It's also a good case.
This is going to be really good. Okay. Here's the case. Okay. He's a 63-year-old neurologist, very particular, very smart man, studies epilepsy, right, in children. He does remote work and he flies himself in a Comanche, right? So he, wait, did he say, okay, some sort of small aircraft, right? And he's dependent on his vision. Best corrects to 20/30, 20/40. And he's historically kind of a habitual -2, -3. He kind of lives with his glasses off most of the time in practice. And he has been wearing multifocal contacts and has loved them. Even as his cataracts has developed, he's loved them. He flies with them. He flies at night. And he doesn't seem to be too bothered by this, right? And so he came in with the strong interest in a multifocal. And I'm gonna flip this around because I have some thoughts, but I'm gonna go to Keith. And I'm going to play the point of the moderator here. And I'm going to say, given his desired near point and occupation and recreation as a pilot, what do you think about your ability to meet his goals and keep him safe with different types of lenses that we have available to him?
Mm-hmm. Now, did you say, is he okay with wearing either glasses or contacts afterwards, or does he want to become?
He wants to be as free as possible.
Okay. What gives me some peace about this one is he was flying around with multifocal contacts and a cataract, and he was doing fine. I think it's still, you have to have a huge conversation with him. You have to document this, that there's a chance you put these in, and this can make you see better. You might even see some of the aberrations better, a little glare, a little halo. Now with neural adaptation, that generally lessens over the course of a year. But if we get
I don't know if he'll get neuroadaptation. He's a neurologist. You know, he might,
Yeah,
he might not buy into that, Keith.
He should understand that more than anybody. But if you get a few months down the road and nighttime's too much of an issue for you, we're talking about an implant exchange. And if he's still that motivated to go after it, I'd be okay with multifocals. We've done multifocals in truck drivers and pilots, but it's after an extensive conversation. And patient has to have some motivation on their side to want to do that. It's also the beauty of light adjustable lens. If somebody's not sure, you get multiple choices to adjust their vision. Now, they're not going to be as independent from glasses, but for some of those patients that are sitting on the fence and they don't know how much myopia they want or monovision or distance, that's right up the alley of light adjustable lenses. You can set them at one spot, let them live with it for a little bit, and make adjustments along the way.
Those were precisely the two things I described to him this morning, right before I got on this call. And he's considering both of those things. And so this is one of those times where I think education plus a little bit of time is going to be really important to patient satisfaction here. And I think that case highlights it. I don't have the answer right now for him because I'm not exactly sure which way he's going to want to go, or I'm going to, agree to go with him, but I'm thinking I can be successful with either the LAL or a panoptics or a trifocal lens. Commonly, I choose a panoptic lens, but one of the other considerations is he's a habitual -2.5, right? So his near point is here. And I said, and I had him hold him up. Where's your near point? And where do you read? He puts his hand up here, and I reach up and I grab his hands and I slowly bring them back. Are you okay if your near point's here? And he said, yeah. It's one of those things where if you don't have a conversation with a habitual, mild to moderate myope, and you're going to put in a trifocal lens, which is going to make them super happy at distance, you have to make sure that they understand where that focal point is going to be and how they're going to have to adjust to that too. Tanner, is your pilot similar to my pilot? Are we seeing the same guy?
He was getting a second opinion after he saw you.
Second opinion.
That's right.
Actually,
He drove immediately to Omaha after he saw me.
Yeah.
There's a lot. I think there's a lot of good points in that case. Going back to what we talked about in the beginning of the podcast with preoperative, historical point of history of multifocal contact lens wear. As soon as you said that, I thought to myself, if he wants maximum freedom from glasses and he's tolerated multifocal contact lenses, he's probably going to do just fine or do well in a trifocal IOL. And then, as you mentioned before, if it's a habitual myope, having a long discussion with those patients about, a near point after surgery, because a problematic near point is a big source of dissatisfaction after these types of lenses. So my patient, a little bit different story, but he's a private pilot. He's like 64. He has very asymmetric keratoconus. So he only really has keratoconic changes in one eye, but it's not severe. I think his Kmax is like 51. And he's probably got 3.5 bucks a sil. I think he's been wearing a contact in that eye. And then his other eye's topography is completely normal, but similar to Brandon's patient, very motivated, wants as much as possible to have reduced reliance on glasses. I was leaning towards like a pinhole aphthera in the right eye, the one that's got the asymmetric keratoconic changes, and then like an EDOF or an LAL in the left eye. And I landed on wanting to do an LAL because he's got the keratoconic changes in this eye, which means he's probably got some type of underlying structural weakness or propensity for weakness in his cornea. So I don't want to necessarily have to adjust that left eye. So that's the plan we talked about this morning. I'm curious if you guys have different thoughts.
I think I think it's a great plan, Tanner. I think the only thing that um, I would wrestle a little bit with just the right eye. And, I can't remember. I think you said he's currently in contact lens. I'd be really curious how well he corrects with glasses, because if he corrects well in a soft contact toric or glasses,
I think he gets 20/30.
Yeah. So with that amount of astigmatism, I might lean more towards even an LAL in that eye, because I just don't know how much, with that 3 diopters of irregularity, the pinhole, I think that there's an art and a little bit of science to how much benefit or reduction you'd see in the effect of that. And if he's okay, still maybe being in a contact lens afterwards, I think it's still a great option. But I think, again, it's the beauty of having all these different choices where we didn't have those before, that there is some consideration to there. But I love it. That's another great case.
Did you do a gas permeable refraction on him? And if so, did it improve him a lot, or was it?
Yeah, but only by like 1 line.
Okay.
Yeah. Cool. Well, great cases. We're going to jump into kind of our last section, which is just post-operative pearls. And I thought what would be nice is maybe just to talk through first sort of what does a normal post-operative period look like for a standard cataract patient who's doing a monofocal implant and looking to be back in glasses when all is said and done. And what is and then we'll maybe jump into some of the refractive cataract differences between diffractive multifocal or LAL. But maybe Tanner, I'm going to let you take a swing. Standard monofocal implant, going back to Dr. Ferguson somewhere out there in the world to get into a new pair of glasses after surgery. What does the postoperative period look like for that patient?
Sorry, I missed the first part of the question. We're just walking through the postoperative phase of a patient that has a monofocal.
Yeah. Yep, standard monofocal, both in terms of, what's a day, a week, a month going to look like, and what should they expect?
Sure. So we, as we discussed before, over 90% of our patients have surgery on back-to-back days. And there's a lot of benefits to that, including, kind of the eyes healing in sync, and then the patient adapting to their kind of new optical system we've introduced into their eyes together, which I think is really helpful for adapting to some of these lenses. And so for a monofocal, we like to see them at 1 day, 1 week, and 1 month. It's normal to have some swelling in the cornea on 1 day after surgery. Even more so if the cataract was more dense or a little bit of a longer case. But by a week, patients should be seeing really well. And if not, then it's even 1 week. It's not too early to look for other reasons for why the vision's not where it should be. And then we like to see them again at 1 month. And at the 3 to 4 week time point is when you can start to discuss with the patient about updating the refraction in their glasses.
Perfect.
Things I think, to look out for are, if the patient's complaining of, all of a sudden at 1 week, increased sensitivity to light or their vision's gone down. Those are concerning signs. You should have the patient come in to be seen. And then on exam, looking for increased signs of inflammation. I think in that like 5 to 10 day range is when you are most concerned about something like, an infection. But those can be seen as early as 3 days after surgery. But I think at the 1 week point, you really learn a lot about where the patient's going to go surgery-wise.
Beautiful. Brandon, can you maybe just differentiate somebody who had a extended depth of focus or diffractive trifocal lens? All those same things still apply, but now we're getting to that 1 month mark, and maybe they have 0.75 diopters of astigmatism left. How's their journey going to be a little different than a patient with a monofocal implant?
Yeah, I think that, folks with monofocals are usually told, you're going to get certainly better quality vision by doing this cataract surgery. But if you have meaningful amounts of astigmatism, you can plan on being in glasses again most of your life after surgery. And those get prescribed commonly, 3 to 4 weeks out, right? As Tanner had said, with an advanced optic, these are patients that are expecting to not have to wear glasses, right? And, while many people with a certainly extended depth of focus and even in trifocal lenses can tolerate, up to that 0.75 or 1 diopter of astigmatism untreated and still do quite well. There may be those that start saying, boy, I'm not seeing as well as I felt like I should. And so if those patients are back in, your office, and they've got that little residual astigmatism, you can start talking to them about, well, what's the plan to address it, right? Because there needs to be a plan to address any residual prescription after cataract surgery, monofocal or not. Monofocal, the glasses are a given. With an advanced optic, it's either, as Keith had alluded to before, maybe they're okay in a single vision lens pair of glasses, and can have that treated at a month. But maybe there's somebody who says, well, I really want to be free as I can, and what's the plan for a touch-up? They may need a temporary pair of glasses, and getting them to about a 3-month mark, right? So that's when the 3 months mark is usually when we start thinking about doing a fine tune, in which case we will commonly do an extra visit after the 3-month mark, called an advanced visual analysis, where we really look at their tear film, their refraction, to make sure everything else is healthy, identify their source of refractive error, and then go ahead and treat it with something like a corneal adjustment procedure, fine tune, like LASIK or PRK. But that 1 month mark can be really important in touching base with those patients, letting them know, hey, you're still in the middle of this process, right? If you've got a little residual prescription, that's okay, right? There are plans to address that. If you need a temporary pair of glasses, that can be available. And then always reminding them that even once that refractive error is eliminated, things like dry eye are important to treat. Things like neuroadaptation are still taking place, and it can take months, even up to a year for patients to adjust to that. So setting the tone of those things, which also need to happen preoperatively, are important to remind patients in that early postoperative period.
Beautiful. Keith, maybe I'll throw it to you. The majority of our patients are on what we would kind of term a drop-a-day program after surgery. Can you kind of talk through the postoperative inflammation control in terms of our use of intracameral medications and then topical medications after surgery, and kind of why we do it the way that we do?
Yeah, so back in the day when I was first started, it was 3 different drops. It was antibiotic 4 times a day for a week, and steroid 4 times a day for a week, 3 times a day for a week, twice a day for a week, once a day for a week, and then whichever NSAID. I mean, that could have been 3 times a day for a month. I mean, that was 10 to 12 drops for the first couple of weeks, and it's tough for patients. It was a big pain point. It was expensive. And then, probably maybe Russell, were you the one that started this, or was it even before you, where we started going to intracameral? And
yeah, when I was a fellow there, we had just switched to intravitreal triamcinolone and moxifloxacin and creating floaters for everyone. And then at my end of my fellowship, we switched to dexmoxicatorilak, which was a very nice transition.
Yeah, good job, Russell. But boy, that has been such a game changer. It's amazing how quiet eyes come back at day 1. Certainly there's still obviously sometimes some edema, but it is so different, you guys, looking at 1 days now compared to 15 or 20 years ago. They're so quiet. Patients love it. Just using 1 drop a day. Risk of infections so small at this point. Compliance is through the roof, and it's just more cost effective for patients too. So it has been almost equally as big of a change as some of the advances in advanced implants. This has been huge for patients.
Yeah. I think about like the patient experience part of things, and there's all these places where that comes into play. IV free sedation, see and do, same day, next day, but drop a day has just been awesome for patients. And to take all 3 of those medicines, put it in 1 dropper, and they just know, hey, you gotta do it once a day. You can do it at the beginning of the day, the end of the day, middle of the day, whenever in the day, but you just got to get in once a day. Tanner, I'd be curious. You sometimes at some of our other conferences or in other communities, you'll hear about dropless surgery, and I'd just be curious. So, giving patients antibiotic and steroid at the time of surgery, and then nothing from a drop perspective afterwards. Boy, that sounds great. maybe, are you doing that at all? And if not, why not? Or what things kind of give you pause maybe about that?
Sure. So there's a number of different kind of approaches for dropless cataract surgery. The one is like a transonular injection into the anterior vitreous at the time of surgery. And there's benefits to that. And then the other common approaches they've talked about is in addition to a intracameral or intraocular injection at the time of surgery is like a intercanalicular punctal plug. That's like a drug-eluting implant. And then there's also another intravitreal injection that people are using. These all have really nice theoretical benefits, not having to take drops after surgery, avoiding, the ocular surface. But I think, we trialed some dropless approaches in our practice. I wasn't here during that time, but I think what people found was that there was more AC reaction they'd like, at day 7 to 10. And not adequately controlling the inflammation can lead to, undesired consequences like CME, and then you're battling that. And so it can kind of just delay the healing process for patients. There are some places out there that are having success with this, but I think the results overall are mixed from an evidence-based standpoint. And I think the way we do drop a day coupled with back-to-back surgery where really they're only taking the drop for 4 weeks, I think is really a great thing for patients. And I feel more comfortable as a surgeon knowing that they're getting some anti-inflammatory continuously from, days 1 to 7 in that early postoperative period.
Yeah, I know for me personally, and Brandon, I'd love your thoughts too as we close out. But for me personally, I've lived through some of those trials of different things, and because it's kind of a dream state to be able to apply medicine, do at the time of surgery, and then not even have to have drops. And I'm still hopeful we'll get to a point where it's really consistent. But to your point, Tanner, kind of what I would term a higher than desirable rate of recurrent iritis, a
Right.
higher than desirable rate of cystoid macular edema. And then I think the other technique that you didn't describe that was commonly used and still sometimes is subtenon's Kinalog injection, which actually gives a nice prolonged
yeah.
anti-inflammatory effect. But particularly in concurrent glaucoma patients and or not, there is just a little higher risk of steroid-induced ocular hypertension. And that can be challenging to treat if somebody responds to that. And the nice part about having a drop is, again, incredibly rare to see steroid-induced ocular hypertension at once a day. But if we ever did, we can pull it off. And it's if you've injected subtenon's Kinalog or if you've injected intravitreal implant, that becomes a little bit more challenging to monitor. So for those reasons, for me, I like the drop-a-day program as it currently stands, and I'm still hopeful we'll find a nice alternative. But Brandon, your thoughts on that?
No objection, Your Honor.
I love it.
I agree. I agree with everything you guys just said.
Awesome. But so maybe just in closeout, I'd just be curious because we're kind of getting towards the end of our time. Just any closing thoughts that you guys would like to offer to those people who might be listening in about anything in the world of refractive cataract surgery before we sign off today?
I think the main thing is it's and always has been, but it's becoming more and more of a refractive surgery. And so we want to kind of start shifting our mind from just taking care of cataracts to helping our patients see like they want to see after surgery. And whether that's with glasses or without glasses, whether they want to stay myopic or go for, more distance vision, understanding our patients' needs, meeting them where they're at, educating them. I love how Brandon said education and time. I mean, when you said that, I just see patients all the time just relaxing when they have education and time. And so just meeting our patients where they need to be and thinking of cataract surgery from a refractive standpoint, I think is, key in these cases.
Yeah, I would say listening to your patient. They'll tell you what's going to make them happy after surgery.
Yep.
It's easy for us to say, no, you don't want to stay a -3.5. But I will tell you from personal experience, I took care of a patient this week who had had cataract surgery elsewhere, who gave her a -2, thinking, well, that's what traditionally we do when somebody wants to be myopic after surgery. But she wasn't happy, right? And so we had to go, and her fellow eye, she was so scared to have her fellow eye done, we went to a -3.5, right? Because she said, this is where I want to be. And she was thrilled, over the moon. And so listen to your patients. They will tell you what is going to make them happy.
The only thing I add is kind of on that patient education piece. I think we talked a lot about time, and I think, we've come up with some things or adopted some technologies that help with this, but I think timely delivery of information to patients and continuing to provide information along the journey is super important. We give all this information to patient before their surgery and then on the day of their evaluation. But I think continuing to provide these patients with information along their journey is super important and help them get into a good place.
Beautiful. I love it. Well, to all three of you guys, thanks for jumping on. Tanner, Brandon, Keith, super appreciate it. A couple of just closing thoughts just from myself. A reminder, if there's any of you guys that are out there that maybe are early in training or just haven't seen a lot of post-operative cataract patients or would really like to kind of listen in on, hey, how do I talk to patients about refractive cataract surgery? We do a lot of hands-on learning. We have in-person kind of mini fellowships at all of our sites. And certainly if that's something that's of interest to come spend a day and kind of observe those conversations, observe that patient experience, we'd be more than willing to have you join us for that. So remember, the world of eye care, it's ever changing. So are we. We're super excited that you joined us. And until next time, we're signing off and have a great day.